welcome you to the online class. Our topic today is intrauterine growth restriction. My name is Dr. Muyiwa Awoleke. I am an associate professor in the Department of Obstetrics and Gynecology, Ekiti State University and Ekiti State University Teaching Hospital, Ado-Ekiti, Ekiti State, Nigeria. At the end of the class, you should be able to define intrauterine growth restriction, popularly referred to as IUGR. You should be able to describe the clinical types, classify the etiological factors, make a diagnosis of IUGR in a clinical scenario, and then be able to outline a management plan for the condition. By way of introduction, IUGR should be differentiated from SGA. SGA means small for gestational age. In this condition of SGA, the babies are only constitutionally small because they probably also have small parents. In other words, that is a normal genetic influence. IUGR, on the other hand, suggests that a pathological process has modified the intrinsic growth potential of the fetus, thereby reducing its growth rate. When fetal growth abnormalities occur, they are usually associated with an increased risk of adverse perinatal outcome. And IUGR is a leading cause of neonatal mortality and morbidity. And the cost of caring for the affected babies is also exorbitant. Certain adult diseases have also been linked to fetal growth restriction. And for these reasons, IUGR is a significant clinical entity that not only should be identified promptly, should be adequately managed. By definition, IUGR is defined as the failure of a fetus to achieve its genetic growth potential. This is characterized by an estimated fetal weight that is at or below the 10th centile for the gestational age. Also, it is when the estimated fetal weight of the baby is less than 2 standard deviations of the mean weight for gestational age. And by way of epidemiology, 10% of infants in any population will be at or below that 10th centile. If we use the 3rd centile as the cutoff criterion, then 3% of the infants in any population will also be at or below that value. Studies have shown that IUGR affects between 3 to 10% of all pregnancies, depending on which centile is used. It involves 50% of preterm stillbirths, and it is the cause in 25% of term stillbirths. Babies that have IUGR have a perinatal mortality that is 8 to 10 times higher than babies who do not have IUGR. And this occurs significantly in about 30% of cases in developing countries. It is also the second leading contributor to perinatal mortality rates after prematurity. The physiology of fetal growth shows that before 16 weeks of pregnancy, the baby's development is mostly by cellular hyperplasia. Between 16 weeks and 32 weeks, there is a combination of both hyperplastic increase and hypertrophic enlargement of the cells. After 32 weeks, the growth becomes mainly by hypertrophic enlargement. Therefore, if there is any restrictive influence on the fetal growth during the first trimester, for example, when the development is mainly due to cellular hyperplasia, this will affect cell multiplication and numbers and result into an overall all-round global symmetrically reduced fetus. However, when the influence or pathological influence is later in pregnancy, say after 32 weeks, only the sizes of these already formed cells will be affected, such that the baby's growth will no longer be symmetrical. We'll go over that again. When the baby suffers a restrictive influence in the first trimester, since most of the cells are multiplying then by hyperplastic increase, only the numbers, increasing in numbers, and this will result into a whole global symmetrical reduction in the fetal size and growth. However, if this pathological influence occurs after the second trimester, for example, then the sizes of those already formed cells will be the one that will be affected, leading to asymmetrical affectation. The types of IUGR. It could be symmetric IUGR or asymmetric IUGR. In rare cases, there could be a mixed pattern. When it is symmetric IUGR, in these infants, all the organs are decreased proportionately. The cause is likely to be an endogenous defect that results in impairment of early fetal cellular hyperplasia. And this could also be due to early but severe nutritional deprivation or chromosomal anomalies or even viral infections. But the key concept here is that these influences must happen early. The thymus on its own becomes about 25% smaller than normal, and this explains why these infants tend to have decreased cellular immunity. On the other hand, asymmetric IUGR, the babies tend to have organs that are decreased disproportionately. This is usually caused as well by an intrauterine deprivation that results later in pregnancy. The uteroplacental insufficiency that results causes a redistribution of flow of blood to the brain, to the heart, and to the adrenals at the expense of less vital organs like the skin, the intestines, and the kidneys. When this happens, there is relative head sparing and a reduction in the abdominal gut and skin thickness. In rare cases of mixed IUGR, for example, when a woman suffers from severe preeclampsia and the fetus also has chromosomal anomalies, this may present with a reduction in the head circumference and or the femur length. What are the factors that affect intrauterine growth? These could be non-pathologic or pathologic. In the non-pathologic instance, the maternal height, the paternal height, the parity of the mother, her ethnicity, the age of the mother, the sex of the fetus, the altitude of residence of the mother, and her race. For example, in pygmies, babies have been found to be approximately about 2.64 kilograms, when they are compared with American Indian babies that have an average estimated weight of about 3.6 kilograms. And these are non-pathologic factors that can influence intrauterine growth. However, pathologic factors could be either fetal, placental, or of maternal origin. This is a table that shows these different components. Fetal pathologic causes of IUGR could be secondary to chromosomal defects, the common ones being trisomies 13, 18, and 21. Single gene defects like Seckel syndrome or structural defects like renal agenesis and neural tube defects also make up this list. Fetal infections, what we regard as the touches, toxoplasmosis, rubella, cytomegalovirus, these viral agents and pathologic agents can also result into a reduction in the fetal growth potential and eventually result into intrauterine growth restriction. The maternal and placental factors result into a reduction in the fetal growth support. While the baby's potential is affected by chromosomal defects or infections, its growth support comes as a result of maternal or placental deficiencies. When there is undernutrition in the mother, or she has hypoxic conditions like in cyanotic heart diseases or chronic obstructive pulmonary diseases, or the mother is on illicit drugs such as cigarettes, alcohol, cocaine, these agents can actually reduce the fetal growth support. When there is placental hypoperfusion, as we can find in antiphospholipid syndrome, defective trophoblastic invasion, and even in conditions like diabetes mellitus, or when there is poor fetal-placental perfusion, such as exists in twin transfusion syndrome, then this also will result into a reduction in the fetal growth support and eventually result into IUGR. Babies who suffer from intrauterine restriction have altered body composition when they are compared with their counterparts who are appropriate for gestational age. There's a reduction in their body fat, a reduction in their total protein, a reduction in their whole body DNA and RNA, a reduction in the glycogen levels and free fatty acids. They also have altered distribution of weight even among their organs and altered body proportions. How do we make a diagnosis of intrauterine growth restriction? This is a key objective in antenatal care. Identifying growth-restricted fetuses will make antenatal care worth the effort. The earlier the diagnosis is made, the better is the expected perinatal outcome. And the diagnosis is based on two important factors. One, an accurate assessment of the gestational age, and two, a recognition of fetal smallness, especially by serial observation. I'll go over that again. The diagnosis of IUGR is hinged on two important concepts. One, accurate assessment of the gestational age of that baby, and two, a recognition of the fact that this baby is actually small, and this can only take place when we have serial observation. How do we obtain the gestational age with certainty? Either by history when we find out the gestational age of the woman, of the baby, by identifying or determining the last menstrual period of the woman. This could be confusing in certain instances, like when the woman became pregnant while she was breastfeeding, or if she had been on some hormonal therapy, if the pregnancy followed an assisted reproductive technique, or she was also on some form of hormone replacement therapy before she conceived, or she had a failed contraceptive experience and then became pregnant. In that case, one needs to be very careful in determining what the last menstrual period actually is. We can also help to identify this age of the baby historically by trying to ask the woman to determine when about the time she first observed quickening or the time she had the positive pregnancy test. Going forward, we can add to the history clinical examination. When we do serial symphysiofundal height estimations, and then we obtain values that are more than 3 units, 3 centimeters below the estimated gestational age, then that could suggest that this baby has suffered some form of restriction. When we have facilities to do early ultrasound scan and serial scans, then we can also identify more definitely the suspicion of intrauterine growth restriction. The crown rump length is the best parameter for dating pregnancies in the first trimester. And when we also have opportunities of doing the scan as a follow-up, the bipedal diameter and the head circumference with an error margin of 7 to 10 days are also very accurate in second trimester. The head circumference is more useful in the third trimester because variability in the shape of the fetal head sometimes makes the bipedal diameter less reliable. And importantly, the abdominal circumference is the single most reliable parameter for evaluating IUGR because it reflects the abdominal fat and liver size, which also correlates well to the degree of fetal nutrition. How do we recognize that a fetus is small? Serial estimation of the fetal size 2 weeks apart from each other. Then adding technologies like Doppler velocimetry can also help not only to support the diagnosis, but also to predict the likelihood of adverse perinatal outcome. There are differential diagnoses that we need to look out for. 1, oligohydramnios. The smaller the amniotic fluid volume, the less likely the uterine size will be reduced. The more likely the uterine size will be reduced. The lower the volume of amniotic fluid, the more the likelihood of a diagnosis of intrauterine growth restriction. Also, wrong dates, and this is very common in women who got pregnant while they were breastfeeding or on a family planning method that failed. Then, transversely lying fetus can also deceptively reduce the symphysiofundal height. And then, rarely, the maternal stature. When she's too tall, it also reduces or too short. It makes alterations in the abdominal gut. When a baby suffers intrauterine restriction, there could be complications on the maternal side or complications on the fetal side. For the mother, these complications could also be due to the underlying disease, whatever precipitated the IUGR. For example, severe hypertension, diabetes mellitus, or even autoimmune disorders, chronic renal diseases. And then she also is at risk of being delivered much earlier than expected. And because of the need to avert poor perinatal outcomes, she's at increased risk of operative deliveries. However, for the fetus and the neonate who suffer intrauterine growth restriction, they could have congenital malformations, like we said earlier on, that these triploidies are, or trisomies are important causes of intrauterine growth restriction. Then perinatal asphyxia is also important, an important complication in them. They could have hypoglycemia, hypocalcemia, hypothermia. Because of the loss of body fat, they cannot regulate their temperature adequately. There is an increased risk of meconium aspiration syndrome. They are more likely to have sepsis and necrotizing enterocolitis compared with babies that are adequate for gestational age. Polycythemia, with or without hyperbilirubinemia, and then sudden infant death syndrome, or even stillbirths. Like I told you earlier on, IUGR constitutes 25% of term stillbirths and 50% of preterm stillbirths. Longer term complications include a lower IQ in them compared with their peers. Learning and behavioral complications also have been noticed in them. They have a higher incidence of seizure disorders, cerebral palsy, because of the perinatal asphyxia that they may suffer beyond the average in the population. And then, according to Barker, he found an association between intrauterine starvation, such as exists in babies who have IUGR, and the occurrence of adult onset hypertension, atherosclerosis, and diabetes mellitus. Interestingly, babies who themselves suffered restriction appear also to have a higher risk of also having babies that may also suffer intrauterine restriction. And these are reasons why this condition should be identified early and treated appropriately. And by way of revision, IUGR, by definition, is the failure of a fetus to achieve its genetic growth potential. We have described it as either being symmetric or asymmetric, or in rare situations of mixed composition. When it is symmetric, the insult that resulted into a restriction of the fetal development happened very early in the pregnancy, in which case it will affect cellular hyperplasia. However, in the asymmetric component, that insult happened later in pregnancy, when the majority of the growth of the fetus is by hypertrophy. And then, in this case, there is the head-sparing component, while you will have a reduction in the size of the abdominal guard and skin thickness. Also, we found that the causes could be pathologic or non-pathologic. In the non-pathologic case factors, it could be because of the mother's small stature or the altitude on which she resides. It could also be because of the gender of the baby itself, because it has been found that female babies are about 150 grams smaller than male babies of equal race, gestational age, and ethnicity. And then we also found that there are pathologic causes, and these could be either of fetal origin, maternal origin, or placental origin. When it is of fetal origin, we we have linked them up with chromosomal anomalies or viral infections. Maternal causes are usually because of maternal undernutrition or chronic medical or respiratory conditions. However, the placental causes are usually related to poor fetal-placental perfusion in cases like twin-twin transfusion syndrome. We have looked at the complications, and these are short-term, as can happen to babies who develop hypoglycemia, hypocalcemia, hypothermia, or longer-term complications like a lowering of their IQs, learning and behavioral disorders, cerebral palsy, and according to Baker hypothesis, the development of adult-onset hypertension, atherosclerosis, and diabetes. How do we prevent IUGR? Because it is, in this case, a situation where prevention is actually better than attempting to cure it. Smoking should be stopped. Women who take alcohol should desist from it. And those who also use substances of habituation should also avoid them. Anti-malaria chemoprophylaxis is also important, as parasitization of the placenta by malaria, the microbes can also affect the transfer of oxygen and nutrients to the fetus. Supplementation with nutrients and bed rest, these are also important for women generally. They should be immunized against viruses, especially prior to pregnancy. And low-dose aspirin has been shown to help to reduce platelet aggregation and increase placental perfusion. And this has helped in a number of cases to reduce the severity of IUGR. And then to treat underlying medical conditions, women who are diabetics or hypertensive should actually have their conditions controlled adequately before they attain or achieve pregnancy. And then correction of maternal anemia. How do we manage IUGR? It could be managed either in the antepartum phase before the woman gives birth or intrapartum. In antepartum management, the goal is to buy more time for the baby. And this will involve following the plans we just mentioned under prevention. Women who smoke should stop smoking during pregnancy. Women who take alcohol should stop taking alcohol during pregnancy. Then we also need more frequent antenatal visits, for example, weekly, so that we can actually keep a closer watch or surveillance on these fetus. We check the maternal weight, the urinalysis to exclude glycosuria or proteinuria, and then the mother is also encouraged to observe or to mark the fetal kicks. And then the sinusoidal height measurement, like we said, when it is less than 3 centimeters below the expected gestational age, then we need to make that, we need to check further to find out why the baby appears to be restricted. Ultrasound scan should be done at least 2 weekly to monitor not only the fetal biometry, but also to go ahead to evaluate the amniotic fluid volume and to do a biophysical profile. These are presently beyond the scope of this topic, but these are important ways of monitoring the woman and the baby during the antepartum period. In cases where delivery may be contemplated and it is uncertain if the fetus is matured, then amniocentesis could be done to identify or determine lung maturity, to also check for the fetal karyotype and alpha-fetoprotein levels. And then, where there are facilities, Doppler studies are advocated of the umbilical arteries, the meducerebral artery, ductus venosus, or the uterine artery. And this will show in cases where the baby is restricted and absence, as we have here, of the end diastolic volume. This is the diastolic volume following the pulsation, the relaxation of the heart in the umbilical artery, and these peaks enter into each other. However, when there is intrauterine deprivation secondary to poor placenta perfusion, then there is an initial absence of the end diastolic volume of blood before we now have a reversal, in which case this condition has become severe and the baby is at risk of imminent death if not delivered immediately. Intrapartum management involves identifying the optimal time based on that particular fetus to avoid maternal fetal compromise and ascertain as much fetal maturity as possible. In other words, the thin line here is to determine when this baby is matured enough to be able to survive ex utero, and at the same time it's not delayed in utero for too long as to result into severe restriction or imminent death. So during labor, this woman will benefit from oxygen administration for the baby's sake. Continuous electronic fetal monitoring is also vital, and where facilities are available, fetal scalp blood sampling can be done to identify any possible predisposition to fetal hypoxia. Early recourse to cesarean delivery is also very valuable, and then we need to possibly include measures to reduce the risk of meconium aspiration, such as intrauterine amnioinfusion. And then in cases where the fetus is less than 34 weeks, they will also benefit from an administration of dexamethasone or betamethasone as country policies or protocols encourage. In conclusion, IUGR is associated with high perinatal mobility and mortalities. And early recognition of fetuses who are at risk is thus indispensable. Management priorities are: 1, to ascertain gestational age of this pregnancy or the baby with precision. 2, identify those modifiable risk factors that can be prevented. 3, optimize maternal systemic disease, if any. And finally, to determine that optimal time for delivery of the fetus. With this, the advantages of antenatal care will be seen. Thank you.